the biology, the biography, and the geography.
Yes. Yeah.
And, and all of those three things. Now, the geography is harder, right? It's harder to change health in a community. And biography is, when you have 20 minutes with a patient. But it's a rethinking of how we need to approach. We call it total health, right? That includes community health and the individual health as well. I began to sort of uh, look into sort of how do we tell the narrative of neighborhoods and concentrated poverty and these ideas that where you live can dictate when you die and where you are in the social pecking order, the social, what a social strata or income or wealth inequality drives health inequality. So in Chicago, and you have this in London, you have the tube stop and we have the L stop. L is elevated. And so if you live in the downtown Chicago, you can live to be 85. And if that were a country, it'd be ranked first in the world. Think, you know, Japan or Monaco. But if you go 3 stops past our amazing #1 in the United States quality hospital, I mentioned before, life expectancy plummets to under 69. And that's a 16-year-old gap. And actually, if you get down to smaller areas of 4,000 people, a census tract, we call them, that gap is 25 years. Literally, 7 stops down what you would call the tube is 25 years. Now, if we gave everybody in Chicago, but in the United States, in the world, a statin for high cholesterol to prevent a death from heart attack, and that's a beautiful drug. Someone won the Nobel Prize for identifying the LDL receptor. That a statin, binds, that blocks the LDL receptor. It's the most perfect precision you can get. You'd add about 20 minutes on to a person's life. But imagine if you could address the conditions that cause a 25-year life expectancy gap or a 16, whatever it is. Imagine how your energy needs to be spent knowing those facts. So we spend disproportionate amount of time on giving people pills and in an inordinate small amount of time addressing the kind of conditions that could really improve health. I showed the train mortality gaps, the life expectancy gaps in neighborhood, the death gaps in Chicago to our board. They were shocked. Now, as an epidemiologist, I knew this for years, but it's telling, I did the narrative along the tube narrative, right? So I did the L narrative in Chicago. This was 6 years ago, and put it in front of our board and said, this requires us to think differently about the root causes. And as an organization, big organization, that purchases a lot, that hires a lot, we have to do something about it. And that's, of course, led to our anchor mission work. But then you've got to pick particular things that you can do. And of course, you've got to measure them. So when we understood that, when we named racism, economic deprivation, poor housing, food insecurity, bad schools, and a whole host of other things as being at the root cause of the low life expectancies, then we said, why is this important to our organization and what can we do about it? So we did 2 other things around data besides just pointing out these big life expectancies. #1, we looked at our patients. We took patients and we put them along the same L tracks. And we just took patients by cost. And our highest cost patients with the exact same diseases lived in the low life expectancy neighborhoods. And then we put our employees. And we took our employees and we took measures of financial insecurity. Our hospital treasuries, we have a lot of data on our employees, all sorts of things. And we said, if you lived in the lowest, 1 out of 5 people who employed at Rush, who lived in our lowest life expectancy neighborhood, were under financial stress on a daily basis. Imagine what it's like to come in to work in a hospital, take care of a patient, right? And so now that's not a foreign concept. It's not some mother out there in the community who's not taking care of her child and It's actually Hank, uh, the transporter, the person you know. So that got to the narrative, right? Because you can't do big change without telling the story of why it's so important to us. The narrative of how you have to think of health. It has to be much broader than the boxes we work in, the hospitals, the clinics, and that framing of health has to be done from the leadership. It's a reframing. It's actually going back to the how health and public health. It's going back to John Snow, right? I mean, John Snow, the great epidemiologist who didn't even know he was an epidemiologist, and the Broad Street Pump is really bringing those two things back together in an organized way through strategy. It's really telling the story of health inequities as being injustice and getting back to the social justice basis for medicine in the first place. And then it's employing those improvement strategies. Uh, do plan, do, study, act. It's not that complicated. So we did it in the homeless population. You know, we've done it in other areas with the racial equity response team in Chicago. It's a mindset, it's a framing, but it's also leadership. It requires people to understand that this is their purpose as a leader in healthcare, is to bring these entities together.